Dr. Fink, we sincerely appreciate the opportunity each year to catch a little time with you and ask some questions that our community here puts on the board. And this year we've got many more than we had last year, so I'll try to summarize some of those as we go and group some of them together.
Sure.
Let me first start out by asking you, since we gathered together last year and did this, are there any new pieces of information, any significant research gains that you've seen that we ought to know about?
Well, there's a lot. I mean, the field is expanding by leaps and bounds, and it's not just the hereditary spastic paraplegia and primary lateral sclerosis fields. It's all of therapeutics and molecular biology of neurology disease. So there's new advances in gene therapy for muscular dystrophy. There's new advances in gene therapy for spinal muscular atrophy. There are planned trials of gene therapy for ALS. There have been advances in stem cell biology and even in some stem cell therapies. So the fields of HSP and PLS are benefiting by all of these parallel advances and major advances. There's, therapeutics are advancing, treatments, strategies are advancing. Within the fields of HSP and PLS, there are a huge number of advances, and more gene identifications, more pathway identifications, more biochemical studies. Yeah, so there's quite a bit.
I think last year we were at like 81 on HSP.
It's approximately 90.
Wow.
Approximately. It's hard to know.
Dr. Fink, some of these questions are closely related. I'm going to read 4 questions to you quickly that and you might just touch on how they fit together. Why am I the only person in my family that has it?
Hereditary spastic paraplegia does not always occur in families. Often it occurs without a family history, just as the first person to be affected or the only person to be affected. There are a number of reasons for this. Recessive conditions typically are not present in the parents and are typically not present in the children, and on average they're only going to affect about 1 in 4 of siblings. So it's just by average, there may be no other siblings affected. There's other explanations too. X-linked conditions usually affect mainly men, and so an X-linked condition can not affect women and so forth. There's a lot of explanations, so it's not uncommon. And also we always have to bear in mind that the person could be the first example of a new mutation. Mutations have to start someplace, and they could then be passed on. There are a lot of reasons why a hereditary condition like hereditary spastic paraplegia may not be a familial condition, may not run in a family.
If our child does not show signs of HSP, could he or she still be a carrier of HSP? Well,
that's a difficult question because, first of all, we always have to talk about the 2 issues. One, the age of symptom onset of the condition in the family. So if the condition begins in general at age 15 to say age 30, well, a 5-year-old is still at risk. You know, they're below the age of symptom onset. We also have to think about the mode of inheritance. If it's a recessive condition, a parent who has a recessive condition, in general, there are exceptions, but in general, a parent who has a recessively inherited condition usually doesn't transmit that condition to the child. The child would be a carrier, but usually not have symptoms. And so we would need to know the mode of inheritance, dominant, recessive, X-linked, or mitochondrial. And we also need to know the general age of onset in the family to know if a person was still at risk of inheriting the condition.
If I have HSP, would my children have it? How could I decide if it's safe to have children, meaning that they not have it?
This is the question of whether or not a person who has HSP is at risk of transmitting it is connected with the genetic type of HSP that person has. If that person has a dominantly inherited type of HSP, then their children are at risk of inheriting it. If the person has an X-linked form of HSP, then if it's a woman, then her sons are at risk of inheriting it, and if it's a man, well, the sons wouldn't inherit it from the father, but the daughters would be carriers. So, and as I say, recessively inherited conditions are usually, with some exceptions, not passed on from parents. So the question is, if a person has the condition, would their child be at risk? It depends on the genetic type of the condition that the parent had: dominant, recessive, X-linked, or mitochondrial.
How common have you seen it in your practice or in your research? How common is it for a parent that has HSP to have all of their children have it?
Well, I've seen that. It's not common. There are a couple explanations. You know, I mean, you could, let's say it's a dominantly inherited condition. In general, 50% of the children would have it. So on average, if there were 6 children, on average there could be, you might expect 3. But if you flip a coin, on average you'll get heads half the time. So if you flipped a coin 6 times, on average you'd get 3 heads and 3 tails. But we all know it's possible to flip a coin 6 times to get all heads. It doesn't happen very often, but it happens sometimes.
Someone asked, how can I volunteer for studies, and what HSP research trials are needed the most?
Well, that's a really good question. There are several sources of information about clinical trials. First of all, stay connected to SPF. Any clinical trials involving hereditary spastic paraplegia and primary lateral sclerosis are announced on the SPF website. Another good source is through the website called clinicaltrials.gov. This is an NIH-maintained website for all clinical trials that are registered through NIH. So those are 2 places to stay informed of clinical trials. How could they, what was the second question?
How could they get involved in research?
Okay, how can they? Well, they would follow up on the information of the where the clinical studies are happening, and they would just contact the investigator.
We had a number of folks who posted different questions about bowel and bladder issues. Mm-hmm. Is there a connection between HSP and incontinence? And my condition has affected my bladder. Over time, I have noticed a pattern of temporary improvement, and then it'll get worse. Any tips on how to manage that? Can you just address generally?
Sure. The bladder is commonly involved in hereditary spastic paraplegia and primary lateral sclerosis. It's sometimes it's the first symptom. It's very commonly involved. By that I mean it's urinary urgency. When there's a need to urinate, you only have a few minutes, and then it's very difficult to remain continent. And that can be treated often with medication. Not always treated with medication, but with other implanted devices and so forth for extreme cases. Usually symptoms can be managed. Occasionally that kind of urgency also affects bowel control, but not as often. On the other side of the spectrum, sometimes hereditary spastic paraplegia and primary lateral sclerosis can cause spasticity of the pelvic sphincter muscles. And this can lead to difficulty relaxing and for example, can cause constipation. And that's another a difficult symptom, and there are medical approaches to that as well. But it's very common for there to be urinary urgency, less common for there to be fecal urgency, and sometimes there can be constipation, or even that may require some medical intervention.
Somebody asked specifically, what medications do you think work best for bladder control?
This is a good question. The medications for bladder control, we start with ditropan, and it's not the best medicine. It's not the most powerful medicine, but if people, and there are other medicines similar to ditropan, if ditropan fails or is inadequate, then I recommend consultation with a urologist. So they have other medications and other approaches, but if it gets to be beyond what entry-level medication can control, I recommend seeing a specialist in this regard.
have a number of questions in a moment about exercise and stretching, but someone asked us, do Botox injections in your legs provide any relief for the spasticity and tightness?
Botox can be very helpful. Botox can be helpful when spasticity is mainly limited to certain muscles. So if there's generalized tightness in all the muscles, then Botox is less effective because you'd have to inject a large amount of Botox in many muscles. However, if there's one group of muscles in particular that's very tight, then you might target that. So for example, if the adductors in the thigh that bring the knees together, if they're exceptionally tight and the rest of the legs are okay, this might be a good target. Or if the rest of the legs are relatively not that tight, but the ankles are extremely tight, well then injecting into the back of the calves can be helpful. Some people have a number of muscles injected, but when it starts to be, in general, a lot of targets for Botox, it's generally less effective. So it can be effective. Botox is not perfect, obviously. If it works, and it doesn't always work, it wears off. And the fact that it wears off is both advantage and disadvantage. If you've got too much and your muscles are weak and your walking is worse, well, that is going to go away. On the other hand, if it worked great and you felt your muscles were more relaxed and you could walk better, well, that's going to wear off too. And so whether it's beneficial or it's deleterious, the effect of Botox is going to go away.
And we just spoke about bladder issues a moment ago. Sometimes Botox can be used to assist
yes,
as well.
It can be used in the bladder as well.
Dr. Fink, we talked last year quite a bit about exercise and stretching, and that's another question from a lot of folks this year. What exercises do you think are most beneficial for HSP symptoms? This one specifically, regarding flexibility, I have difficulty spreading legs in and outward. Is this spasticity? Anything be done with that? You want to talk about
Sure.
stretching and exercise?
Yeah. The exercise, I recommend exercise. And this is not because I have done a scientific study about exercise. I haven't. It's not because it's been well studied in the field either. There are a couple reports, but in general, the impact of exercise is not well studied in primary lateral sclerosis or in hereditary spastic paraplegia. But the reason that I'm a big advocate of exercise is because people have told me, hundreds of people have told me that exercise helps. And I reflect that back. I say, well, you know, this person says this exercise helps. Why don't you try that? And then they do, and they come back and I say, how's it working? I say, made a big difference. So it's the recommendation for exercise, which I support enthusiastically, is not based on scientific study. It's based on anecdotal evidence that people have reported to me and in the community. And second, it's based on the fact that when people stop exercising, like if they injure their ankle or they, for whatever reasons at work or school, they don't have time for it for a period of time, people have said when they stopped exercise, when they interrupted their exercise for 2 weeks, 5 weeks, their functional abilities decline. And so I've heard the advantages of exercise and the disadvantages of interrupting exercise. Okay, now what kind of exercise? Well, this needs to be individualized. So in general, if there's weakness, we need to figure out a program to strengthen the muscles that are weak. If there's tightness, we need to figure out a program to cause relaxation and stretching of the muscles that are tight. And there's usually a pattern which is different for individuals. Some people, their quadriceps are tight and their hamstrings are not so tight, so we'd want to work on stretching the work on stretching the quadriceps. Stretching the hamstrings is less important for that person. For other people, they may have a lot of weakness in lifting their knees with hip flexion. For them, the program would focus on strengthening hip flexion. So one person would be stretching their hamstring, somebody else would be working on stretching their quadriceps, somebody else would be working on hip flexion strength, and somebody else might be working on all three. Somebody else might be working on balance. Somebody else may work on speed, that they're moving too slow. So the point is that one exercise prescription for one person doesn't fit everybody. It's got to be individualized. And second of all, it's got to be both specific targeted muscles, like strengthening the hip flexion. That's a targeted muscle strength. And then contextual exercises that involve the whole body, like that would involve balance and movement. And so these would be things like therapeutic horseback riding, or walking, or climbing gym, or yoga, or some activities that would involve the whole body all at once, not just isolated muscles. We need to do both. Targeted muscles, focusing on the problem areas, stretching or strengthening, and then contextual exercises that use the whole body to accomplish that. And so working with a trainer, getting an exercise prescription from a physical medicine specialist, this is the way to start. And then start slow, increase slowly, keep records. It's a lifelong commitment. And people who have done this say it helps. There should not be injury. It should be done safely. It should be done with respect to other health conditions. But otherwise, I think it's important.
As someone who's dealt with those exercise issues myself, I think you made a great point that I would like for you to emphasize maybe just a little bit more. It's easy to go out and find exercises to do, but to really achieve the most, you need to know which muscles, which parts of your body are affected, and have someone help you design a program.
Right, it's important.
And physical therapists or medical professionals, exercise professionals can be very helpful in that regard.
Yeah. And one other point is that often physical therapists may be unfamiliar with the words primary lateral sclerosis, and they may be unfamiliar with the words hereditary spastic paraplegia, and they may feel that because they're unfamiliar with it, that they don't want to hurt anything and they don't know what to do. And so we are often in a situation of educating the physical therapist about, I have spasticity, I need help with this. Forget the name of the condition, just deal with the symptom of spasticity. Or I have weakness, forget the name of the condition, just help me deal with the weakness. In general, if it's tight, it needs stretching. If it's weak, it needs strengthening. If it's balanced, we have to work on balance and speed, all of these things.
A couple of questions about genetic testing. Someone asked, would taking the genetic test and getting those results and confirming what you have be advisable? And then someone asked, if I have not done that, would I still benefit from a consultation with you or a neurologist?
Well, about genetic testing, genetic testing today does not inform treatment. So it doesn't matter if you have SPG4 or SPG40, it doesn't matter. It doesn't say, based on the genetic test, we're going to prescribe a specific treatment. Not today. And if treatments were going to be determined by the result of genetic testing, well, when that day comes, testing could be obtained to see what you qualified for. So you don't, and it would be available then, it's available now. So testing is not done in general terms to identify treatment. Testing is done for other reasons. For some people, it's important. Not for everybody. It's not important for everybody. If a person feels unresolved or unsettled because they have this life-changing symptom that doesn't go away, it's getting worse, and they say, well, the only diagnosis they get is to get someone examine them and say, well, I think it's this. And for some people, that's unsatisfying until there's a laboratory test that can confirm it. And then it brings resolution or conclusion to that diagnostic odyssey, that long search, sometimes over years, about trying to find the name and the specific diagnosis. And genetic testing can, it doesn't always, a lot of times it fails, but it's often can find the diagnosis and bring conclusion to that diagnostic search. Genetic testing can be used for prenatal diagnosis. So if someone says, you know, I want to know if our child will have this, the separate decision making from how it's going to affect the outcome of pregnancy, whether they're going to continue the pregnancy to term or not, that's another issue. But some people just want to know whether the child is going to have the condition or not. And if the condition has been diagnosed genetically, then that information can be applied to prenatal testing. Other people want to go further. They say, you know, we have this condition, my husband has this condition, and we've decided that we don't want our child to have this condition, and we don't want to terminate a pregnancy. We want to do pre-implantation genetic testing, and so we want to do an in vitro fertilization and only become pregnant if the blastocyst or the embryo does not have the mutation. So all of this kind of pre-implantation testing and prenatal diagnosis is possible if the disorder has been diagnosed genetically. And if a gene test has shown the type of HSP. So if prenatal testing is not important for a person, if there's no concern about that, and if there's no issues about this, I feel unresolved because I don't exactly know laboratory confirmation what the type of the condition is. If these are not issues, then the person does not necessarily need genetic testing. And one other important point is that genetic testing does not obviate the need for other laboratory tests and imaging studies that exclude other conditions. This is important because let's say a person has a gene test that shows a mutation. That doesn't mean we don't need to check their B12. That doesn't mean we don't need to make sure there's no structural abnormalities of the spinal cord or the vertebral body. We still need to exclude other causes, even if there's a gene test positive. So a gene test cannot be used instead of diagnostic evaluations to exclude other conditions. But you still need to go through that kind of diagnostic search, the clinician does.
Are there, that you know of now or maybe in the future, clinical trials or other activities that you might be excluded from if you did not know your specific type?
Oh, of course there will be. There already there are a couple of emerging clinical trials that are under discussion, and for example, there's under discussion the development of a gene therapy trial for SPG15. The trial doesn't exist yet. It's under discussion. It's in the planning stage. But when it gets underway, it would involve people that had SPG15. And similarly, there's been a trial of medication that's applied to SPG5. And so if there's more trials of SPG5, then you would have to have that particular type to participate in that particular trial. And similarly, there'll be other trials that are more type specific, and to participate in them, you need to know your type.
Dr. Fink, we live in a time when a lot of our state governments and our national government are debating issues about CBD oil, marijuana. Some folks are asking, you know, what do you think about that? Does it improve symptoms? What about the medical processes involved with that? Could you make some comments about that?
Well, at the University of Michigan, I'm not permitted to prescribe medical marijuana. And I also work at the Ann Arbor Veterans Affairs Hospital Medical Center, and we're not permitted to prescribe medical marijuana. So I have not prescribed it. Now, I know I've attended conferences dealing specifically with the symptom of spasticity. And well-qualified, experienced physicians are prescribing medical marijuana to treat spasticity. And I've seen their reports, and plus reports in the literature, and it does have a benefit. I'm aware of the benefit. Although I have not prescribed it myself, I'm aware of the benefit that other clinicians have reported. In general, the benefit is not dramatic. But the benefit from oral baclofen is often not dramatic either. It has a different mechanism, we think, than baclofen, and so it might have an additive effect. You know, it has a different mechanism of action, and it could be an additional benefit. It's not a major improvement, but it might be a supplemental improvement or an adjunctive therapy. I have nothing negative to say about it. It's maybe reasonable to try. I wouldn't use it, or I wouldn't recommend it as my initial therapy, because I think that baclofen and tizanidine are more powerful. So I would try those other medicines first and see how far we could go with them in terms of benefit and side effects before adding it. But I think it's reasonable, sure.
Dr. Fink, what tips or advice would you have specifically for children that have HSP and their parents who are working with them?
Okay, so the question about children with HSP, it's a very big question. A lot of things to unpack here. One, the most important thing for children, and this would apply for teenagers and adults too, but we're focusing on children. The most important thing for parents dealing with children and for teachers dealing with children that are affected is not the ability to walk. That's not the most important issue. The most important issue is self-esteem and feeling okay about themselves and having friends, being integrated with their family and their school, doing well in classes. But their general sense of self-esteem is the most important issue. And so that we want to work to achieve that. We want to work to maintain and achieve their sense of independence as they're getting older, as they're getting to be a teenager, and they're getting more autonomous, independent, pursuing their own interests. We need to facilitate their independence, their autonomy, their choices, their integration with their school, with their friends. So important. Those are the first issues. Anything else we do is secondarily important to maintaining those. Now, with regard to their walking, exercise, stretching, more exercise, more stretching. However, it has to be done in a very skillful manner because this is a lifelong commitment, and we don't want exercise to become a problem that is a source of a battle with the parents and the child's rebelling, and this requires a lot of tact and skill and nuance. But in general, maintain a healthy, active lifestyle, be as fit as possible, incorporate exercises that are fun, like horseback riding or swimming or going to the climbing gym or gymnastics or dancing, dance therapy or just dance, yoga, stretching, soccer, whatever the child enjoys, capitalize on it. It's very important. Now, the other part that is very important is that when the condition begins very early, these are generalizations, there are exceptions, but when hereditary spastic paraplegia begins very early, like with the first steps, the child's walking on their toes, often the condition does not get worse. So it's sort of what you see is what you get. It looks very similar to cerebral palsy. Now, there are exceptions, but often when the condition begins very early, the symptoms do not get worse. And so a parent might have read about the condition gets worse, but not always. It may not get worse. Now, sometimes when the condition begins after infancy, let's say it begins at age 10, it does get worse. Usually it does. But even then, when it begins after infancy and the symptoms are progressively, slowly getting worse, often the symptoms stop getting worse after a number of years. Not always. There are exceptions. This is not a guarantee. But many times we see during a growth spurt, let's say an 11-year-old is going through a growth spurt, and now their walking was very subtle at age 10, now it's worse at age 11, it's worse at age 12, and by age 14 they're now having significant difficulty walking. But by age 16 it's not worse than it was at age 14. And by age 17 it seems to be about the same. And so it got worse for a period of time in early adolescence and then seemed to reach a plateau, and that's very common. Not for everybody. Sometimes it just gets worse and worse. But the point is that the course of symptoms in children can be non-progressive. What symptoms in early childhood, age 1 or 2, may not get worse. They could, but they may not get worse. Similarly, after symptoms begin, they may get worse for a period of time and then stop getting worse. And also, sometimes they just continue to get worse. So the point is that you can't make a prediction. You can't make a prediction from one brother to the sister or 2 children in one family. You can't say, well, my father had it at this age and he had symptoms, and so we predict that for the child. Everybody's an individual and there's a lot of variability. So the concepts for children are self-esteem, integration with their friends and family. These are the goals. And as far as walking is concerned, maintain exercise as much as possible in a way that the child is engaged and it's not a punishment. And then sort of be very cautious about making predictions. To say we expect it's going to become worse. It may not become worse. Yeah.
I have had 2 episodes of sudden extreme weakness in my legs and I could not stand. Is this normal HSP?
Sudden worsening with HSP is not typical. There can be, by sudden, if you mean from one moment to the next, that's very unusual. I would think it could be medication related, it could be fatigue related, it could be pain related. There could be other factors that made it worse at that moment. But in general, symptoms of hereditary spastic paraplegia usually by themselves don't vary from one minute to the next. They can, and if they do, vary over the course of the day, over hours. You know, if a person's tired or if they've been sitting for a long time, they can get stiff. So there can be that kind of slow, and you can have good days and bad days. But in general, symptoms don't suddenly change.
Someone asked, will changing my diet stop or slow the progression of my disease?
The issue about whether diet will change the symptoms is unknown. I'm not aware of diet modifications that will make the symptoms much better. But we're always open to exploring that and wondering if there's vitamin supplements that might help. We typically or often prescribe a vitamin E supplement and a coenzyme Q10 supplement. These are not mandatory, and there's no proof that it would help. But it seems reasonable if a person has a progressive neurologic condition to take an extra antioxidant, and vitamin E and coenzyme Q10 can be beneficial. However, having said that, a little dose of vitamin E might be helpful, but a mega dose of vitamin E can be toxic and can injure the nerves. So a little bit of vitamin E, in terms of 400 units as a max, I would endorse, but mega dose of vitamin E I would not endorse.
Someone asked questions about the kinds of shoes that people wear with these conditions. Any thoughts and advice on types of shoes?
Well, no, because there's so much variation. But some people who have difficulty bringing their toes up may benefit by an ankle-foot orthotic device, an AFO. And some types of shoes provide more ankle support than others. So sandals don't provide any ankle support. But a high-top tennis shoe or a boot may actually be providing some ankle support. And so it's not an AFO, but it's more support than a sandal. The other part is that for many people, the shape of the foot can change. Toes can curl in, and people may be walking on the outside of their foot. And so shoes that can counteract some of those changes may be more comfortable, but it's really on an individual basis.
One of our ladies asked, is HSP progression faster for women due to hormonal issues?
The question is whether male hormones or female hormones affect the nature or the severity of symptoms. I don't think it's known because there's so much variation between one person and another that it's hard to know that the variation is worse in men or worse in women. I can't answer that more specifically.
We have a question about speech. Someone says, why is speech sometimes affected? I can talk, but my vocal cords seem strained. Is this an HSP thing?
Well, the issue about vocal cords and speech in hereditary spastic paraplegia is complicated because in general terms, speech would not be expected to be involved in the uncomplicated forms of hereditary spastic paraplegia. Speech, articulation, and the sound of the voice, the vocalization, should not be affected in uncomplicated hereditary spastic paraplegia. So, if that's the only symptom that might suggest that the condition were complicated, then I would want to talk with an ear, nose, and throat specialist or a voice specialist and see what's going on with the voice. Is there something on the vocal cords per se? Is it from gastroesophageal reflux that's affected the vocal cords? Something else that's affected it. On the other hand, there are some types of hereditary spastic paraplegia that do affect the voice and do affect swallowing and do affect speech articulation. Those are more complicated forms. And certainly in primary lateral sclerosis, the speech and the voice and swallowing can absolutely be affected. But if a person has only intermittent voice problems, I would want to rule out other vocal cord disorders before attributing it to hereditary spastic paraplegia.
Is some degree of spinal cord atrophy per an MRI common with HSP?
The question about spinal cord atrophy and hereditary spastic paraplegia is very common. The word atrophy, I want to be very precise about. Atrophy is meant to imply that the structure used to be big and now it's small, that it's getting progressively smaller. That's when we say something is undergoing atrophy. It's true that studies of the spinal cord, if we measure the spinal cord, the lower parts of the spinal cord, on average, not necessarily for every person, but on average, the lower parts of the spinal cord, in the thoracic cord, for example, are smaller in their diameter than people who don't have hereditary spastic paraplegia. But it's not clear if that's getting worse over time. It may have been that way for many, many years. So we don't have necessarily serial data where we measure it at age 5 and age 15 and age 25, not yet. But it's true that the diameter of the spinal cord in the thoracic region in particular is often smaller.
Is the degeneration that's happening with HSP in my brain, my spinal cord, or both?
For hereditary spastic paraplegia, the problem is primarily in the spinal cord. I don't know, I mean, there are some types of hereditary spastic paraplegia in which there's also brain involvement. It can be cerebellar involvement with ataxia, it can be cognitive involvement, and so on. I mean, the range of conditions with hereditary spastic paraplegia is great. There's 90+ conditions, all grouped together as under the same umbrella as hereditary spastic paraplegia. So some of those conditions do involve degeneration in the brain. But if we say that a person has the, quote, uncomplicated form of hereditary spastic paraplegia, most of the problem is in the spinal cord.
What are some side symptoms of PLS that might show up?
Primary lateral sclerosis has tightness in the legs, weakness in the legs, and also involvement of the upper extremities, speech, and swallowing. The pattern of involvement for primary lateral sclerosis is variable. The majority of people have leg onset first. Some people have speech and swallowing onset first. Some people have upper extremity onset first. So while the majority is legs first, then arms, speech, and swallowing, there are other patterns. The bladder is commonly involved. One issue that we see sometimes in primary lateral sclerosis is difficulty with emotionality. That is, sometimes people may express an emotion, for example, laughter, when they're not really happy. And they may cry when they're not really sad. So it's a disconnect between what the emotion they're experiencing and what they're demonstrating. And that happens sometimes in primary lateral sclerosis.
Dr. Fink, again, we sincerely appreciate your service as medical advisor for this group and your work in these areas.
It's my pleasure.
For so long. Let me ask you just one final question as we end this. With the new research, the new technologies, with our growing community, we've got a great group of folks here that seems to be growing. We're thankful for that. As you look at all of that in your capacity as a board member and a medical advisor, you have any advice for us on how we move forward in helping find those treatments and cures as an organization?
Sure. Well, this question about the directions is something I face all the time. It's a matter of looking at opportunities and prioritizing. We have to say, among the options we have, what should we do? And we can do everything, but we can't do it all at once. And we can't do any of it alone. So we have to pick what we're going to do, and we have to work together. And we have to expand our resources. This is critical. What are resources we're talking about? Well, financial resources, research resources. Research resources are things like databases, animal models, laboratory models, cell-based models for drug screening, natural history studies. These are things we need in order to move the field forward. So we need to expand our resources. Personnel, people involvement, community involvement, that's a resource. We need to pick our projects very carefully because this takes a lot of energy, a lot of time, a lot of money, and we need to see what we think is going to work. How do we decide what's going to work? Well, we look at other areas, we look at the fields. We're not the only neurodegenerative disorder. There are other neurodegenerative disorders, ALS, spinal muscular atrophy, multiple muscular dystrophy, multiple sclerosis, so forth and so on, spinal cord injury, and see what progress is being made and how the progress is being made, and make sure that we're doing the most effective work we can. in general, there have been a lot of progress in other areas in terms of gene therapies for muscular dystrophy is emerging, and gene therapy for spinal muscular atrophy is emerging. And we can learn a lot from them. One thing that we say is that we should do first what is most important. So we have to be very careful and think clearly, creatively, strategically, what is the most important today? What do we need to do today? What is the most important? We should do that, and we should empower other people to help us along this way. We should. Everybody needs to be empowered. We need to give leadership and empower other people. Within our own organization, we need to empower people to give them agency to facilitate this. Now, as far as how can we move the field forward, I have some specific ideas, you know, gene therapy ideas and drug therapy ideas, and these are not you know, exclusive. We can go in a couple directions, but we need to have a very clear idea of what our targets are. And I would also put this out there, that very important is that we have benchmarks on our progress. If we say we are going to make a 10-year commitment to developing gene therapy for hereditary spastic paraplegia, if we as an organization make that decision, that's fine. Then that ought to translate then into what's a 1-year benchmark, and what's a 2-year benchmark, and if we have a 1-year benchmark, what's a 6-month benchmark? How do we know if we're on track to achieving what we decided we want to do? And let's say in the 3rd year, somebody comes up with a new idea altogether in another field. Maybe we want to abandon what we're doing or take advantage of what they're doing. We may not stick with our plan, blindly ignoring all the advances in other fields. But my point is, we need to think strategically about exactly what we want to do. When we've made that decision, we need to translate that into a plan and monitor our progress with benchmarks.